So I'm now just going to talk about headaches and sinusitis and whether the two are related or not. As ENT surgeons, or as an ENT surgeon, a lot of the people who walk through my door have been sent to me with a headache and the promise that it's due to their sinuses, and that if I fix the sinuses, the headache will go away. And I'm sure a lot of us get this. Blessed are those who do not get headaches, but most of us do at some point in our lives. And the International Headache Society have got a classification. There's primary, secondary, and other. Primary headaches are things where there's no anatomic or physiologic explanation, although there are theories, and that's things such as migraines or cluster headaches. Secondary headaches are those that are caused due to a known disease, which is where sinusitis can come in. And then the headaches of other origin, which is multiple but includes the cranial neuropathies, Tolosa-Hunt syndrome, things like that. Now, there are a lot of differential diagnoses for sinus pain, and these are the three top differentials: tension type, facial migraine, cluster headaches. And the thing about them is they can all present with autonomic symptoms like rhinorrhea and nasal obstruction, and this is where the waters start to get a bit muddied. They can also be triggered or made worse by sinus disease, and again, this is where we run into a lot of problems. So what is sinus pain? Well, it's that improves and worsens with the course of the disease. It's accompanied by clinical, endoscopic or radiologic evidence of sinusitis. It worsens with things like flying or diving or change in weather. It improves with a decongestant or local anaesthetic, and it meets those EPOS criteria. But even this isn't a perfect science. Now, if we look at the accuracy of pain-related symptoms associated with a sinus headache, facial pain has maybe at best a 30% sensitivity for acute sinusitis. Headache, less than 50%. Pain with leaning forward is a bit better. And maxillary pain is only about 11% sensitive. So chronic facial pain is actually rarely of sinonasal origin or rhinogenic origin. In fact, if you look at patients with purulent rhinosinusitis, less than 20% will actually report pain. And about 40% of patients who have chronic rhinosinusitis who've had good surgery and a good result, a lot of them will still have pain after their surgery despite their sinuses looking normal. So this is a study done 12 years ago, but it's a fantastic study looking at 100 patients who had self-diagnosed sinus headache. And what they did is they had this multidisciplinary clinic with neurologists and ENT surgeons and radiologists, and they reclassified all of these patients with self-diagnosed sinus headache. And they found that a large proportion, I think it was something, it was 80-something%, were migraine. And if you add the unclassifiable, it was over 90% of these patients were not sinus disease. But most of them reported blocked noses and postnasal drip, changes with weather, allergy or altitude. But 3% of these patients actually had rhinosinusitis. So what is sinus headache? Well, it's usually unilateral. It's moderate to severe in nature. It's usually on the same side as their rhinologic symptoms, such as rhinorrhea. It's exacerbated, as I mentioned, with skiing and flying and respiratory tract infections. They tend to respond to antibiotics, but not always, and it tends to be a throbbing or aching nature. Now, if we look at specific sinuses, the frontal sinus tends to be on the medial side of the orbital roof. The maxillary tends to have more dental pain. But the sphenoid sinus is a bit special, and its pain can actually be anywhere. And the thing about these patients is most of them do have pain or some form of headache. It gets worse with movement, and it doesn't respond to typical analgesics, and it can be anywhere in the head. They also have a blocked nose, postnasal drip, rhinorrhea. They can have ocular disturbances and epistaxis, so it's a bit of a unique sinus. When we look at imaging, if you scanned everyone out there on Victoria Street, 30% would have some sort of abnormality on their sinus CT scan, yet they'd be asymptomatic. And 60% of patients who have facial pain thought to be due to chronic rhinosinusitis actually had a normal scan and a normal exam. So non-rhinogenic pain really is a diagnosis of exclusion. One of the most common is tension type facial pain. Due to time constraints, I'm not going to go through that, but what I wanted to go through was to discuss migraine, because this was the most common other diagnosis that patients are misreported as sinus-related pain. So we know that it lasts for 4 to 72 hours. There are lots of theories as to the cause of migraines. But they're really common, more common in women. They're polygenetic, and most people have an affected family member. And they're severe. They tend to be unilateral, but a quarter they're not. And they can have an aura, but not everybody does. And I wanted to talk about the prodrome with migraines. The prodrome can start anywhere for 48 hours prior to a migraine, and there can be lots of different ways, and most people aren't aware, because if they just yawn more or they're a bit hyperactive, they're not necessarily going to link that in with the headache they get 2 days later. But the thing about the prodrome, it's actually considered a focal neurologic deficit. The thing about it is if you get them, you can then abort your attack. They're a warning sign, so you can take action, as opposed to those who don't have them. The people who get the prodrome tend to have more triggers, so they're more easily triggered to have their migraine. But the take-home message about the prodrome is that there's a greater risk of ischemic stroke in the migraineurs who get the prodrome, particularly the aura. It tends to be more common in young women, and they're thought to have a posterior circulation infarct. So you have to be really careful when you've got a young woman, maybe a smoker, a bit overweight. If you're going to think about starting those vasoconstrictors like triptans or ergots in these patients, you have to be really careful. So facial migraine, if we look at those people who have a self-reported headache, 58% actually have migraine. If a physician diagnosed them, who are actually less accurate, 88% actually had migraine. And of those who do actually have migraine, most of them have also previously been diagnosed with chronic rhinosinusitis, or 42%. And those who do have migraine, there's about half of the people out who have migraine are not diagnosed. So the cause for the misconception between sinus disease and migraine, there's a lot of reasons for it. So most migraine sufferers do get a blocked nose, particularly during an attack. They also have rhinorrhea. They also have mucosal edema if you examine them, and that resolves when you treat the migraine. They'll also get better with a vasoconstrictor like Drixine. If you give a migraineur Drixine, a lot of them will actually feel better. And chronic migraine sufferers often lose those typical features of migraine, and it can present more like chronic rhinosinusitis. And also, if they have chronic rhinosinusitis, they'll get more frequent migraines. And if you treat allergic rhinitis, the frequency of migraines get better as well. So that's why this picture is really quite muddy. So how do we work out of our patients who has migraines and who's got sinus disease or who has both? Well, this is a really simple, migraine surgery is another thing that a lot of plastic surgeons are doing. And this was discovered by a plastic surgeon doing endoscopic brow lifts, and he found that after, a lot of patients' migraines went away or were better. And what the thought was that the zygomaticotemporal nerve and auriculotemporal nerve were sacrificed or decompressed during the surgery, and that improved it. Also, a lot of people who respond to Botox will often benefit from the migraine surgery. Now, these are 3 simple questions you can add, for example, on the back of a SNOT 22 form, to try and rule out who may or may not have a migraine. And they're really simple. It's have you had a headache that's limited your activities for a day or more? Were you nauseated or sick? And does light bother you when you have a headache? And this has actually got a pretty high positive predictive value, particularly if you answer 2 out of 3. And if you answer 3 out of 3, it's incredibly high. And that's something really simple that we can do. This is also another thing is that you can use to screen our patients. If they've got a history of recurrent nausea or photophobia or auras with their headaches, childhood history of motion sickness, comorbid conditions like fibromyalgia, anxiety or irritable bowel, or if they've got a family history. So the other thing is if you treat a migraine and do nothing to their sinuses, a lot of people's sinus symptoms will get better. Just quickly, because this is becoming a bigger problem these days, is cervicogenic headache, which is a huge category of different diseases. But the one I wanted to point out was the cervical spine. And that's because most of us in this room will have cervicogenic disease of some sort. And once you get over the age of 40, 100% guarantee you'll have an abnormal MRI or CT scan of your spine. And this is getting worse because of this phenomenon. And if I convert it into kilos, but it's also for the Americans in the room, there's pounds there. If you flex your neck forward by up to 60 degrees, which looks pretty severe on this slide, but I'll show you another slide which will make it a little bit more real. That's 27 kilos of pressure on the discs of your cervical spine. And you think, well, when does an ENT surgeon do this? I mean, I do most of my septoplasties endoscopically now, but I still do wear a headlight for certain things. And it's hard to get the bed up high enough, but you can. So, in summary, the most common causes of chronic facial pain is not sinus disease, even in people with overt sinus disease. And so we really need to correlate what's going on with their symptoms in the radiology and exam findings. And it's really important that we actually do screen these patients with some of those migraine questionnaires. So just quickly, if we're talking to these patients, if we've got someone with a daily and constant headache, it's not going to be rhinogenic. If the location is pressing or symmetrical facial pain, it's more likely to be tension type. Or if they've got trigger points and a sensation of facial swelling, that's more likely to be tension type as well. If it's severe, that's likely to be migraine or cluster headache. Mild is more likely to be tension. And with the distribution, unilateral is again more likely to be migraine or cluster headache or paroxysmal hemicrania. If it's aggravated by leaning forward, that could be rhinosinusitis or tension pain. And if it responds to antibiotics, potentially rhinogenic. A lot of antibiotics do have anti-inflammatory properties to them, so not an absolute guarantee. So this is a really nice slide in a paper published this year of just how to work out what type of headache patient you have, and I'm more than happy to provide that reference for anyone who'd like it. Thank you.